The tests that we're going to be talking about today are the less commonly used ones that many of you may not be using regularly in your practice, but some that may be useful for you to know about. Now, these are sort of new ones that some of you may be asking about too, and some people are asking about getting these tests done. So that's why I think it might be also useful to talk about this. So let's just summarize what we talked about last time. So last time we talked about some really key blood tests that are done commonly. And the main one that's done universally across the globe for managing and monitoring and even diagnosing type 2 diabetes now is the HbA1c. This is the most common test because it's easy to do. It's a quick blood draw and it gives us an idea of your blood glucose level over the last 2 to 3 months. It's an average blood test of your blood glucose. Then, of course, with diabetes, we do other tests as well. That includes your liver, kidneys, and your blood counts. They're just checking your overall bodily function. They're ensuring no side effects related to medicines and that you're not getting any impacts on your kidney function and other organs related to glucose. So making sure they're not under undue stress. The thyroid and possibly other tests, if you're getting symptoms of tiredness, might be useful. And then urine samples, which generally are there to check for stress on the kidneys. Now, ultimately, they are the ones that help you paint a picture of your health. So let's look at some of the other tests. So the ones that we're going to talk about today include something called C-Peptide, another one called HOMA-B, another one called HOMA-IR, HOMA-IR, insulin level, quickie, and a really long one, a long name called the euglycemic clamp. So little spoiler alert, most of you will not ever need to use these other tests. And they don't form part of my routine clinical practice. And they tend to be reserved either for the research or as specialist purposes. A couple of them might become useful in the future, but we'll go through those. And they are gaining a little bit more interest. So that's why I also think it's worth going through them. And I'll give you my opinions on them too. So we'll start with one that I think is going to be most useful, which is the C-Peptide. This is a more commonly used one out of the ones I've just mentioned. And it's generally a widely available test and pretty low cost for hospitals to do in the UK. But if you're requesting it privately, it can be much higher cost. And it can essentially help to understand whether someone is in a different form of diabetes called a latent onset form of type 1 diabetes. So it helps us to understand whether you're getting type 1 diabetes or type 2 diabetes, because what it does is it looks at the beta cell function of your pancreas. And it's really helpful because it can tell us about the insulin function within the pancreas compared to if you're receiving insulin function outside of the body, which we call exogenous insulin, whereas insulin that's made within the body is called endogenous insulin. The way it works is essentially you have the insulin, then it breaks down, and part of the breakdown molecule is something called C-peptide, and that's what's measured. So in type 2 diabetes, just thinking about what actually happens, initially in type 2 diabetes, we get a raising insulin level because the body is pushing out more insulin to push more glucose into the blood cells because it's not functioning as well. Then over time, the pancreas gets more tired, then the insulin levels start to drop, and then eventually we have much less insulin. And so that's when we need to think about having insulin exogenously. So that's from outside as an injection or in other ways given in the body. So when we do the C-peptide test, if it's normal or high and you've got a raised A1C, then that suggests it's more likely type 2 diabetes that's causing you to have raised blood glucose levels. Or if the C-peptide level is very low or non-existent, then it suggests that the pancreas isn't really working. So your raised A1 or blood glucose level is actually not related to type 2 diabetes, which is insulin resistance, but it's more type 1 diabetes, which is autoimmune or a destruction of the cells within the pancreas that produce insulin. So that's an example within type 2 diabetes. And the really good thing about it is that it can be used anytime. You don't need to fast for it. And if you're taking insulin already, you can do the test and it gives us a good idea of your pancreatic function. Doesn't get confused between the insulin that you're getting from outside of the body. So like I said, it can be useful in diagnosing latent autoimmune diabetes in adults, also known as LADA or LADA. And that's basically like a slow progressing form of type 1 diabetes. And over time, C-peptide levels are initially preserved, but they decline, but they just decline faster in latent autoimmune diabetes in adults, much faster compared to type 2 diabetes. And so it might be helpful in guiding whether people need to have insulin or not, because if they're not creating any of the C-peptide, then certainly they're going to need insulin. But if they are creating it, then it tells us that the body can still have this ability to create more insulin. So that's where medicines like tablets might be more helpful. And then very rarely we can get very rare tumors in the pancreas, one specifically called an insulinoma. Insulin leads to very high C-peptide levels and is dangerous because it can cause consistent and persistent hypoglycemia, very low blood glucose levels, even with people who are not diabetics. That's one to be mindful of. So it can also be helpful with monitoring pancreas transplants or islet cell therapy. So these are quite specialized reasons to do the C-peptide to make sure that they're still working okay. Like I said, to measure for hypoglycemia, very low blood glucose, and trying to find the reasons for that. And then looking at potentially whether there is remission for type 2 diabetes, looking at the level of beta cell function. But I'd say we really don't do that at all. I think a really good reliable indicator still remains your HbA1c. So there's some limitations of it. I think it can be influenced by the kidneys. So if the kidneys aren't functioning so well, it may be elevated because the kidneys aren't able to get rid of this protein fast enough. And then in fasting tests versus stimulated tests, the stimulated test, basically you give a dose of glucagon, and so that can give you an understanding as to whether there's better beta cell reserve because it would cause it to rise. But without the glucagon, it may not be so high because you may not necessarily have a need for more insulin around the body at that time. So like I said, type 1, it'll be low or absent, and type 2, early on, it'll be higher or normal. Then over time, it can decline in type 2 or much faster in latent onset diabetes. Second test we're talking about is something called the HOMA-IR. Now, this one is used quite a lot in research, and it's really a mathematical calculation between insulin levels and glucose levels. So HOMA-IR stands for Homeostatic Model Assessment of Insulin Resistance. And it is used in clinical practice a little bit, to clinical practice meaning with patients. And basically, the calculation is your fasting insulin level times by your fasting glucose level, and then divided by 405, or a different number depending on what units you're using. So if it's normal, which would normally be lower, so less than 2, it tells us that your insulin is sensitive to the glucose. But if it's high, so more than 2, then this can suggest insulin resistance. But again, the practicality of this test compared to doing an A1C, which we know when it's rising above the specific thresholds, is limited. It is possible that you could have insulin resistance that is below the threshold for prediabetes, which is 42, and that this could pick it up. But really, what we're thinking about here is whether that's really meaningful, whether you can do anything useful with that measurement. So yes, like I said, it can be used for really early detection before we're getting really high, much higher blood glucose levels. But if you're getting a regular A1C test and you think you're in the high risk categories, then that's probably more appropriate and more easily available to get. It can obviously track, if you're doing the HOMA-IR test, it may track your insulin sensitivity with interventions. But again, I'm using the A1C for that. And we can only use the HOMA-IR test when you're fasted, rather than doing it at any time. And so it's not giving us a general dynamics of your insulin resistance. It's just giving us a static number. Another test that might be used is just checking your insulin levels. Now, this is something that people often ask. They're like, well, I've got my blood glucose level, but we know that insulin is affecting that. So can you check my insulin level? But this is where it's not very helpful really at all. So you can check it in a fasting condition, but checking a standard insulin level doesn't give us that much information. We need to check it in comparison to the glucose level. So that's why the HOMA-IR may be more useful. So it's usually useful when it's calculated alongside that. And to calculate the HOMA-IR, you do need to have a fasting glucose test and a fasting insulin test. So of course, if you had type 1 diabetes and you did an insulin level and they hadn't had any insulin injected, then it would expect to be very low, and that would be more indicative that the high blood glucose level is more likely to be type 1 diabetes, and that would be done more in an acute setting very early on if someone presented more as an emergency with possible type 1 diabetes. The other test that's used in research is something called Quicki, Q-U-I-C-K-I. And so that's another sort of mathematical calculation to estimate insulin sensitivity. And the way to check that is, again, with fasting tests. You check the fasting insulin level and you add that to the log of the fasting glucose level. And then you do a 1 divided by the log of fasting insulin plus the log of fasting glucose. This can be a bit more tricky to calculate because of the logarithmic algorithms required. Essentially, the calculation is the opposite to the HOMA-IR. So a higher value will indicate greater insulin sensitivity, and a lower value will indicate resistance. And that's just simply because of the way the calculation is done. So this is more of a gold standard. It's much more accurate than the HOMA-IR, but it's more expensive to do and it's not really used that commonly. So it's not really used probably because of the logarithmic calculations that are required. So HOMA-IR more widely used because of its simplicity and practicality. Quickie is more sensitive, but it may only be used when getting absolute precision is more critical. So that's much more likely in research. Then we come to this one called the euglycemic clamp. The euglycemic clamp. This is one that I wasn't aware of until I started going to do more of my research, and that's because this is not used at all in clinical practice. And it's really the gold standard for assessing insulin sensitivity. It's because it gives us a direct measurement that they're testing directly on the body. So the way it works is you have an insulin infusion at a constant dose being provided into the body to raise insulin levels to what we call a hyperinsulinic state, so having a lot high insulin. But at the same time, to avoid low blood glucose, then you provide a glucose infusion to maintain a blood glucose level at a normal level at around 5 millimoles per litre. Then you measure this by looking at the rate at which the glucose needs to be infused to maintain that blood sugar level, and that will give us an idea as to how sensitive the body is to insulin. So if there's a lower glucose, so if there's a lower M value, which is the rate at which glucose comes through into the system, then this might indicate insulin resistance, or a higher M value will indicate more insulin sensitivity. So the advantage of this is that it's very, very accurate, but of course it's a bit cumbersome, it's expensive, it's not used in clinical practice at all, but we can get some very good, reliable results with this. And then there's the HOMA-B test. The HOMA-B test is closely related to the HOMA-IR test. And this one specifically is another mathematical calculation based on the fasting glucose and the fasting insulin. And this gives us an idea as to how well the beta cell function is. The beta cell function is what creates the pancreas, creates insulin within the pancreas. So we want to see how well that's functioning. So this gives us that idea. But again, clinically, when we're thinking about it in practice, this seems quite similar to the C-Peptide, because what we're doing is C-Peptide is looking at the function of the pancreas and how well it's functioning, and so is the HOMA-B. Difference is, with HOMA-B, it doesn't tell you the difference between insulin that's being injected and insulin that's already in the pancreas, the difference between exogenous and endogenous. So then you start to think, well, the C-Peptide is probably more of a practical test for more wide ranges. It has a wider range of use. The second thing is the HOMA-B needs to be a fasting test, because we need to have the fasting insulin and the fasting glucose, whereas C-Peptide doesn't need to have this fasting required. So I don't think it's very practical, and there's a better test, which is the C-Peptide test. So again, I don't think this is a test that you're going to come into contact with, really. So this is just a summary of those rarer tests. So we've got C-Peptide, HOMA-B, HOMA-IR, insulin level, Quickie, and the euglycemic clamp. So you're not going to be using these really once you've got a higher A1C. The one that's going to be most practical, I think, is the C-Peptide. If you're thinking about whether you need to be on insulin instead of medicines to find out really what's working for you, and some people are taking insulin and medicines and you want to find out really what's having the impact, then a C-Peptide is going to be more helpful for you. And also in diagnosing the rarer types of diabetes, including latent autoimmune onset of diabetes. The other test that could potentially be helpful, but again, I think we're looking at the A1C being more useful practically. So the other test is a HOMA-IR, which gives you a measure of your insulin resistance. But again, if you've already got a raised A1C, that's the most reliable test, as it comes down to see if you're improving insulin resistance. Perhaps combine those tests can be useful for you too. So if you're particularly interested in getting position tests, those might be more helpful. The other ones probably wouldn't recommend, and they're probably much more expensive and more confined to research. So I hope that's helpful. Stick to the A1C. Consider these others if you're interested, but they won't really make part of routine practice. We'll check in soon.